So the term interest is derived from fiduciary law, and that's where we adopted that particular terminology from. And so looking at the things that a physician would need to look out for on behalf of their patients, or that a teacher would have to look out for on behalf of their students. And so that's where the interests language came from. And we did intend it to be interpreted broadly. I'm not sure whether attempting to come up with an exhaustive list of all the possible interests that could be considered is really an appropriate task for the panel. And I think, as you alluded to, that in different settings and in different countries, the interests that might be at stake might vary. And I don't think we could probably ever hope to identify and categorize all of them. And so I think if we came up with a sort of a basic list of common interests in terms of things like welfare and privacy and socioeconomic interests and that kind of thing, but left some discretion to individual research ethics boards in particular locations that may be better suited to identify interests that may be uniquely at stake in that particular setting that may be desirable. That's something that the panel can talk about in the next few days.
So Martin, I'm going to, this is payback for putting me off last time, so I'm going to purposefully be quite provocative, so I've warned you ahead of time. From where I sit, being a researcher, having done a lot of research in very vulnerable populations in cardiac arrest and other, and in the critical care setting, what I mostly commonly see when I review clusters, and I did at CMAJ, is one, are cluster designs appropriate for the question? So, which you guys did not get at. So the issue for me is, would you be better served with an individual-based randomized study versus a cluster? And the reason that's important is that's where the ethical issues arise. If you choose the wrong design, you're in trouble. You'll see where I'm going with this. If a true cluster is where if the cluster design is appropriate for the question, then by default, how do you get, from where I sit, how do you get a collective consent? The issue is a collective one, not an individual one from where I sit. If it's a true cluster design, you're trying to affect a populations-based cluster effect, I don't understand why you need an individual-based consent under most conditions. So the default to me ought to be the other way around, I think. So waived or some variation of that. I guess my other comment would be, how much information does one provide the community, and what type of community engagement, if what I said, number 1, 2 is true, what information do you provide to the community ahead of time, not after the fact? That just ruins the design, causes contamination, selection bias, and all kinds of corruption of the appropriate of the science. So I would vehemently disagree with that. So the idea then is, what do you provide the community ahead of time prior to randomization? What level of community engagement would be essential and appropriate prior to randomization and institution of the design? And then finally, we have opt-out clauses in Canada. I mean, Susan's code of our new Tri-Council code talks about quality assurance versus research. Quality assurance must be done if we're to improve our quality of care. Anything we do in that regard, you would say, oh, it's not research. Well, it's not. It's quality assurance. And we need to decide ahead of time what we're going to do in that regard and whether we're going to use these appropriate designs more and more. So from where I sit, I would suggest that the opt-out clauses ought to be used. We need to basically think of it much, much more differently than I'm hearing right now. So individual ethics are probably less appropriate than collective ethics, and there are ways to get at that. Otherwise, you're using the wrong design.
Thanks. So I think hearing a number of things from you, and I completely agree that at some point, probably near the beginning of this discussion document, we should probably undertake some discussion of when is the cluster trial design appropriate and when is it not. And that's probably something that many of us agree on. And so as the panel goes forward, I think that's something that we should probably think about putting near the top of the document. As far as I think a couple of the concerns that you raised are going to be addressed or at least touched upon in the discussion about how gatekeepers ought to make decisions about enrolling communities or clusters in cluster randomized trials this afternoon, and sort of what criteria they use to decide whether or not it's appropriate to enroll a particular community or cluster in a cluster randomized design. As far as when do you need to get, or when is it appropriate to seek individual informed consent? I think what you need to keep in mind is that yes, the interventions may be happening at a cluster level, but in a number of cluster randomized, in a large proportion of cluster randomized trials, the community is just the unit of randomization, and the level of intervention is actually on the individual community members. And so if you hadn't been using a cluster randomized design, you would be seeking consent from those individual subjects. You're just using the cluster randomized design for whatever legitimate reason it might be, whether it's avoidance of contamination or the fact that it's a community level intervention, but you're actually doing something to those individual subjects in a way that meaningfully threatens their welfare or privacy interests. And so there are individual interests at stake in a lot of cluster randomized trials. Not all of them, you're right, but there are certainly individual interests at stake in many cluster randomized trials. And I think to adopt a stance where you only need to get permission at the community level, I think undermines the autonomy of those individual cluster members.
I think that Kathy wanted to make a response as well.
One quick question on the quality improvement or patient safety aspects. If in fact you were doing something that was sort of clearly a single facility, a quality improvement intervention, sort of confined to that, and never to be published, although I know people don't necessarily use that as the criterion, and perhaps where some of that kind of information is protected because peer review type information, I think at least in the US, is often held to be non-disclosable in legal situations, then I think you're making a case that a lot of this might not be so pertinent. But if in fact you were trying a major, let's say patient safety, and I regard that as kind of equivalent to a lot of quality improvement efforts, and they were being done in multiple sites, different kinds of heterogeneous populations, and a variety of other kinds of differences, you might well expect that information, especially if you had multiple arms and or types of interventions, and then some sort of usual care kinds of efforts, where the idea really is to inform public policy or to inform professional associations, those that are concerned with, say, quality improvement, then I think these issues will arise more and do deserve, whether it's randomized trials or cluster randomized trials, they do deserve considerably more sort of thought about how to go about getting informed consent. I may not have quite understood your point on the last, but I think there are different levels of patient safety and quality improvement activities that do essentially fall into the category of research rather than purely quality efforts internally to a facility or an organization.
Mohammed Ansari, OHRI. My question is, I have two questions. One is there a difference between legal and ethical issues when it comes to cluster randomized trials? Should we be worried about legal issues as well? For example, right to dissent. Not only right to consent, but the other was you gave an example of bed nets and control being patients who can be considered not as part of research. So I was thinking, let's say if I were that villager who was not getting a bed net, then what I would think is, and let's say the other village is in proximity to mine, and I would think that most of the mosquitoes will eventually migrate to my village, and the bloodthirsty one, and that could actually impact my outcomes.
I think what we're attempting to do is identify sort of a minimum set of ethical requirements, and I think it's beyond the scope of what we're attempting to do to try to address all the potential legal issues that may vary from jurisdiction to jurisdiction, and even between provinces in Canada. I think we'd have a difficult time addressing the legal issues that may arise. So what we're attempting to do is to identify sort of a minimum set of research ethics regulations that then may be useful to research ethics boards and regulators and to investigators. And if legislators want to come on board and adopt what we're proposing, then great. But I don't think that we're hoping to address the particular legal differences from jurisdiction to jurisdiction. As far as whether control communities or whether citizens in control communities count as being research subjects or not, and not being an expert on migratory patterns of mosquitoes. What we're trying to get at is that if the study team is not actively doing anything to a particular group, including collecting identifiable private information or doing anything that may otherwise be thought of as potentially affecting their physical well-being or what have you, that's the heuristic that we're using for whether somebody is a research subject or not. And so to a certain extent, it is up to the discretion of the particular sort of investigator and research ethics board that's reviewing the case as to whether people ought to be considered research subjects or not. But the point that we're trying to raise is that the key we're trying to sort of clearly lay out who is a research subject to ensure that they're adequately protected. And also in laying out who isn't a research subject, we're just trying to ensure that the whole process isn't over-regulated. And so I think it would probably require some local discussion as to whether considering the control community's research subjects would be appropriate or maybe over-regulation. And in the absence of any definite proof that the mosquitoes are all going to massively flock to the control communities, you could probably say that usual practice and not deviating from sort of usual public health policy probably counts as no intervention at all. And in the absence of any other reasons for considering those control community members research subjects, then you would have to make a really strong argument that you should consider them to be research subjects. And in the absence of sort of compelling evidence that there's going to be a mass mosquito migration.
Okay, Catherine Lowe response again, and then we'll move on to the webcast.
This is sort of a quick response. I think I take a slightly different view than you've heard from Andrew, because but it may fall into the category of, are there secondary effects or potential harms that might be visited on those control? Now, you used the example of, would mosquitoes migrate? I had assumed that bed nets, either killed them or rendered them sterile or something, and it was kind of immaterial. But I can think of lots of situations in which people in control communities might either learn about something and decide they want to go partake of whatever is going on in the neighboring village, or where certain kinds of things might move human beings. You could imagine some kind of cluster trial that tries to deal with drug sales. And if you intervene in certain neighborhoods and you get drug dealers off those particular corners, they're going to go somewhere. And if in fact they go to a control place, you have invoked or imposed a harm on them. So it seems to me you couldn't possibly lay out every conceivable possibility for harms in that direction, but it may be incumbent as part of your guidelines for people who want to try to do these sorts of trials to think it through and raise with their IRBs any potential harms of that sort that might be visited even on control communities or groups?
The first comment for information is that Laura Lee Balkwell from the Secretariat of Research Ethics in Ottawa notes that TCPS2, which is a tri-council policy in Canada, does offer a definition of research participants that I think the research team needs to look at. Then there's a set of comments which is really about the lens that I think we've applied and the focus, as Andrew spoke, on jeopardy. So again, Laura Lee Balkwell sort of said, why has the sole emphasis on our analysis been on jeopardy? Would studies that stand to confer benefits not be subject to RB scrutiny under this model? And then Elaine Collier, who's with the National Center for Research Resources at the NIH in the US, also, I think when Andrew was talking about patients' interest being protected by the practitioner within the normal ethical codes of practice, said, well, who decides when interests are in jeopardy? The view of the practitioner may not be the same view as that of their patient. So those are two comments that would be good to perhaps get Andrew to respond to if he can.
Sorry, could you repeat the first comment, Jeremy?
So the first one was, I think when you framed the discussion around the research subject, you particularly framed this in terms of the jeopardy of interests. And basically, I think the question is, why did you largely focus on jeopardy? Would studies that stand to confer benefits not be subject to RAB scrutiny under this model?
I think that may arise from the historical lens of bioethics, in the sense that the field arose largely in response to incidents and studies in which subjects or individuals' interests were unreasonably jeopardized. And so that may be just sort of the historical lens. But I think what we did in trying to define a research subject, the sort of the conceptual approach to it, was trying to identify what's the difference between being a patient in a physician's practice and being a subject in a clinical trial. And the essence there is that even though in a clinical trial you are accruing benefits, you are also putting your interests in jeopardy for the purpose of developing generalizable knowledge. And so that's in spite of and independent of any kind of benefits that may accrue to you as a result of participation in a clinical trial. And so that's sort of the approach that we used. And so the essence of being a research subject is, independent of any benefits that may accrue to you, is to have your interests jeopardized as a result of research participation. And that's something that as far as consent goes, is something that people need to take on willingly. You know, I'm sure everybody will gladly sign up for the benefits associated in being in a clinical trial, but it's the downsides that cause the problems.
There was a second point about physicians and patients, Jeremy.
Yeah, I think when we talked about the maybe sort of there being indirect effects on patients in, say, quality improvement or knowledge translation trials that target their physicians or their nurses, the assumption was that the normal protections within the healthcare professional to the patient relationship would actually, if you like, protect the patient from inappropriate indirect problems. And I think the question that Elaine Collier was sort of saying is, well, is that always going to be the case? Can we be confident that the view of the practitioner is the same as their patient, and that they can fulfill that role of protecting the interests of the patient within their professional ethics codes?
I guess what we're trying to get at is that sort of the role for the physician or nurse or healthcare professional who's intervened on in the setting of a cluster trial. If they were to undertake their normal practice, then what they're doing, sort of to sort of summarize is that they're acting generally in the patient's interest. That's sort of what they do on a day-to-day basis, in terms of that's the sort of the essence of their professional activity. And the fact that they're being intervened on in an attempt to improve practice doesn't change that. I don't think that we're expecting that they're consciously taking on the role of a protector of patients' interests, but what they're doing is, in their day-to-day job, independent of how they're intervened upon in the setting of a cluster randomized trial, is that they're acting in their patient's interests. Whether or not they take on some sort of protector role relates to studies in which the physician may actually be a gatekeeper and allowing access to clusters of patients, and that's a separable issue that I think will hopefully be touched upon this afternoon.
Ray Sagener, Ottawa. I'd like to ask a question about waiver of consent. Getting consent, Andrew, is a hassle. It takes all sorts of time. It costs me as an investigator all sorts of money. It's expedient for me to say it's just not feasible, or if I don't get consent, I won't get consent of everybody, and it might introduce a bias. Who knows? And it's expedient for the investigator to suggest that, to impute that, to posit that. The question is, if the REB, sometimes it's easy for the REB to agree and say it clearly is not feasible, or there's clearly an issue about bias. What sort of test might the REB impose to assess whether indeed feasibility or bias are issues in terms of waiver of consent?
What test does your REB use?
Well, this arises actually from time to time, and what I do is I say, show me the money. Go with, we won't waive consent yet. Try not to scuttle the process of consent, and show me that there is an issue.
I think that's exactly right. Is that the burden of proof is on the investigator. If they're making that claim, they need to back it up with some substantive evidence.
Okay, we have a couple of questions about the issues of opting out for, I think, cluster-level innovations or interventions. One is, I think, more of a comment from Bruno Giraudot from France, who notes that the very nature of participant consent must be discussed in relation with the nature of intervention, since for some of them, there is no opt-out option, e.g. fluoridation of tap water. So I think that was a comment in the first session that we delayed to this session. And then I think Laura Lee Balkwill comes back with a more specific issue or comment. It's not always the case that communities have no choice but to opt into an intervention put forward by the authorities. For example, in Winnipeg, there are neighborhoods that refuse to be sprayed with mosquito pesticides due to health concerns. In trials studying these types of community-wide interventions, how closely are researchers expected to investigate the rights of communities or segments of communities to opt out?
So I hope we've addressed Bruno's point in that the feasibility of consent quite often does turn on the nature of the intervention that's being evaluated, and as far as how much credence or how much we want to give individual communities the ability to opt out. I think, again, that's something that I hope will come up in this afternoon's discussion and later on in the next couple of days, in terms of who has the legitimate authority to actually make decisions on the part of communities, or even communities within clusters, as the case of the Winnipeg study might be.
My name is Annette Brown, and I'm with the International Initiative for Impact Evaluation. So to give you an idea where I'm coming from, we fund evaluation of development programs in low and middle income countries. So first I want to thank Kathleen for bringing up the point that a lot of issues in the international sphere, there are a lot more issues probably than have been coming up in the papers and the discussion, so on, and I'm not going to raise all of them here, but I will raise one now, which is not unrelated to the last point. And that is, I encourage you, as you move forward, to talk about the cases where there's a separation between the designer and implementer of the intervention and the research team. So the majority of evaluations that we fund, even those that are experimental design evaluations, are of programs that have been designed and are being implemented by somebody completely different. So two concrete examples. One is not one that we fund, but regional government in China says, we want to try 1 egg a day in schools in rural communities to see if that improves health and educational outcomes of children. And we understand RCCs, so we will randomize across schools as the researchers tell us. We're going to go find researchers. We just want them to tell us, does this improve outcomes or not? But the design of the program, and the program is all the government. A second example would be combination prevention programs for HIV incidence in developing countries as well. These designs are coming from a large array of international donors. The implementation is sometimes government, sometimes NGOs in these countries, and the researchers are being brought in often to help with matched pair randomization, but to do the research, not to talk about the design of the intervention. And so the question is, where does the, again, where does the responsibility lie on the part of the researchers in all of these questions about opt-out, informed consent, and all of those things?
I would suggest that there are types of studies typically under the rubric of community-based participatory research that would invoke from the very beginning some elements of, and it may be needs assessment starting as early as that, but certainly including elements of the design of studies in which you bring in the stakeholders from the community. They may be people who are sort of in fraternal organizations, community organizations, perhaps religious organizations, and involve them from the beginning. And that may be a partial answer to what happens when researchers parachute in with study designs in their back pockets and don't really try so much to get at all kinds of issues at the community level, community broadly defined. So I would encourage perhaps some thought to whether some of these sorts of principles that y'all are trying to develop can be somehow expanded to include the principles of community-based participatory research, which is a fairly well-known, I think, fairly well-known approach, at least in health services research, if not drug trials and so forth per se.
Thank you. And I think your comments about specific issues in developing countries that echoed the issues that Kathleen raised about vulnerable populations are well taken. I think one thing the panel is probably going to have to consider in the next couple of days is the issues that have just been raised aren't necessarily specific to cluster randomized trials. They would arise anytime an investigator parachutes in with whether it's an individually randomized trial, whether it's a prospective cohort study or what have you. And so we'll need to consider how much detail we want to expend on issues that aren't necessarily unique to cluster randomized trials, but are nonetheless noteworthy of mention.
So we have two comments which are around cluster trials of knowledge translation or QI interventions. The first is from Deborah Cook from McMaster University, and she says, some QI communities and clinician scientists distinguish between A, cluster randomized trials testing an intervention that is a KT strategy, for example, education and audience feedback versus education alone, where the aim is to try and get a proven, effective intervention into practice, e.g. aspirin for post-myocardial infarction, from B, cluster randomized controlled trials testing an intervention with an unknown effect on outcome, e.g. evaluating whether school sex education decreases pregnancy rates. And her question is, how will you distinguish consent issues for these two situations in the guidelines?
In the first example, the intervention would be addressed to healthcare practitioners, and the hope that the intervention may result in the uptake of a practice that has downstream beneficial effects for patients. And so, the way I'd approach it is the way that we'd sort of a step-by-step approach. And first, who are the research subjects? And so the target of the intervention would be the healthcare practitioners. And then as far as the patients go, the approach that we've taken is that the patients would not necessarily be subjects unless they're interacting with the research team in some other way to ascertain the outcome, either through interviews or using identifiable private information. And so you would need to get the consent of the healthcare practitioners, but unless the patients are research subjects, then there's no need to seek consent. Whereas the school-based study of sort of novel or implementing sex ed curricula So the intervention would be targeted at the students. And so the students would be research subjects. And as far as the teachers go, who would be doing the teaching, the question is what's actually being done to the teachers to get that novel curriculum off the ground. Are they being subjected to some kind of experimental education intervention? Yes or no? And so the students would be the research subjects, and the teachers may be, depending on the kind of intervention under study. And so, if there aren't any compelling reasons to waive consent, then informed consent from the students would be required. And as far as the teachers go, it depends on whether they're research subjects or not.
Stuart Nichols, University of Ottawa. Most of the discussion, I think, seemed to draw informed consent from issues of autonomy, protecting autonomy. But I just wanted to clarify the language you used around autonomy, because you talked about autonomous individuals, which seem to relate to competency of individuals, but also autonomous choices, which seem to relate to sort of deliberative decisions. Of course, autonomous individuals may not make autonomous choices. So I just wanted to clarify that, but also sort of what was it that's intrinsic about autonomous decisions that made it worthy of respect and protection?
And so the point's well taken that we probably need to be clear about we need to be respecting autonomous choices by autonomous individuals.
So the next comment around a kind of KT trial was from Tom McDonald from Dundee in the UK, and I think this was a kind of a cri de coeur from a researcher interested in trying to do this. Should we compare new guideline policies with previous guideline therapies when the evidence that the new is better than the old is largely opinion-based? And delaying the new, in brackets randomly, allows a cluster randomized evaluation that would be of benefit to everyone, as we will actually discover what is better. How can this be unethical?
So I gather what the question gets at is what degree of evidence is sufficiently compelling to make the community decide that new guideline is better than old guideline, and sort of what degree of evidence is supporting the new guideline. And if it's largely consensus or opinion-based, then there may actually be a need for a cluster randomized trial to establish which guideline approach or which clinical approach is superior, so that by the time guideline number 3 comes around, it can actually be based on good evidence.
Could I add just a quick couple of responses? One is that one assumes, perhaps erroneously, that new guidelines will have been based by now on authoritative systematic reviews or comparative effectiveness reviews in which the grade for the strength of evidence, if not high, at least is moderate. Perhaps you could get away with low, but one hopes that in this day and age you don't get guidelines that are simply good old boys sitting around a table. And so I'm not sure I quite understood the premise, or at least maybe I disagreed with it. The other issue is whether some of this also needs to be thought of in terms of delayed start trials, in which eventually somebody's going to get, or crossover designs, in which these clusters are going to eventually get what it was that the first people got, and whether there are any special situations that you all need to be thinking about for that.
So that would be something like step wedge design would achieve that.
I beg your pardon?
A step wedge design would achieve that.
Okay, all right. And that's in there.
We can take that into account.
Dean Ferguson, Ottawa. I'm struggling with your definition of research subject. I would think that anybody that contributes to your results, so contributes data actively or passively, would be considered a research subject. Not dependent on what they know, what they get, but they contribute to your results. And if we don't call them research subjects, what do we call them?
I think what we wanted to be clear about is that, so say hypothetically you were evaluating outcomes based purely on administrative data sets and not collecting data from, you're not collecting identifiable private information, you're not collecting blood samples or doing any other kinds of physical examinations. But if you have an administrative data set that gives sort of gross aggregate infection rates, do you need to consider every single patient who ever passed through the doors of the hospital ward who has their data collected in an administrative data set? Do you need to consider them research subjects? And are their interests really at stake when you use that administrative data? And we concluded that no, there really aren't any key welfare interests or privacy interests or what have you at stake, and so we don't need to consider them research subjects. And what do you consider them? You can consider them patients, but I'm not sure that research subject is the right label for them either.
I don't think it's a question of risk or what's at stake as they contribute to your study of questions. So that's your sample frame. Mm-hmm. And I would think that they would be considered research subjects. For consent in that's a whole different issue.
Yeah.
Right. But I think it's an important distinction, else we can't go anywhere.
Okay, so this is from John Hermes, who's in the VA in Boston. And I think this is trying to clarify some of the kind of the principles outlined, Andrew. If the study intervention is deemed no more than minimal risk and or consent is unfeasible, to what extent does having to collect private information, say through prospective medical record review, preclude receiving a waiver of consent?
The question sort of turns around what degree of risk is involved in prospectively collecting identifiable private information from health records. And there is some literature and I think some regulation that clearly specifies that type of data collection falls under the minimal risk category. Certainly it may have some implications, as Kathy touched upon, on sort of the adverse consequences of inadvertent data release. But sort of that sort of historically and in regulation falls under the minimal risk category. And so the same as for clustered randomized trials, just as well as for prospective observational studies and that kind of thing, that consent wouldn't necessarily be required if the only subject level intervention is the use of identifiable private information.
Okay, so quickly, I want to make sure I understand this. So part of the purpose of defining the research subject, I take it, is defining the purview of whose interests the REB ought to be protecting. So am I understanding you correctly that if the REB makes a determination that a certain population are not research subjects, then it is not within their ambit, their moral ambit, to be protecting their interests? Is that an accurate understanding?
Yeah.
Okay. So then, if that's the case, I guess I would sort of raise as a question whether or not that's really, from a regulatory standpoint, maybe that makes sense. The common rule is quite straightforward about that, for example. But does it really make sense that REBs have no obligations or duties to protect or look after the interests of entities who are not research subjects, but who are nevertheless affected by the implementation of the research? So, for example, your question, your point earlier, about secondary effects, there was a very famous housing voucher study in the 1970s where property values of all sorts of people who were not in the study were impacted by that. Now, surely someone who is responsible for making risk-benefit assessments has to be responsible for thinking through the externalities of the implementation of that research. So if it's not the REB, then who should that be?
I guess, I think in addition to considering the interests of individual research subjects, it certainly is fair game for the Research Ethics Board to take into account the interest of community. So in addition to taking into account the interests of research subjects, there are occasions and research studies where it's reasonable for research ethics boards to take into account the implications for communities. And so there's a history and a bioethics literature on the interests of communities. And so that may apply, or may to a certain extent address your question, not completely. And so, but I think we do, there is some, it's an unresolved question in terms of are there other interests that aren't sort of germane to research subjects and germane to the purview of research ethics boards? I think that's something we can talk about further.
The question really was about ethicists. My prejudices about ethicists is it's all principle and not thinking about practicalities and feasibility. I'm obviously caricaturing here. So it's quite reassuring to find an ethical framework that takes into account feasibility, whether something's doable or not. So if that's the case for cluster randomized trials, shouldn't it be so for individually randomized trials, where it's often not so much not feasible, but very difficult to get what one would think of as being properly informed consent? You can get a box ticked, but you may not get really informed consent. And we're talking here again about ethical guidelines for cluster randomized trials, and we're taking feasibility into account, which I think we should. But I just wondered how that fits with an ethical framework. And we also talk about developing countries as sort of more of a vulnerable population, and that's often, the two are often put together. But in terms of consent issues in trials that I've been involved in, quite often the villagers in villages are very active participants in the whole process of understanding about a trial, learning about it, giving consent for the village before randomization, in a way that I haven't met in the same sort of way in many, quotes, developed countries. So there's two issues around there.
Okay.
But I think stand up for the ethicists if they're going to be talking about feasibility. It's great.
You raised the point of you're glad that we're taking into account feasibility, and I think the thing that we want to be clear on is that just as current research ethics guidelines are not aspirational documents and things that you should strive to, but things that you should actually do in practice, our research ethics guidance for cluster randomized trials is going to be much the same. We're not going to set a list of things that people should aspire to, but we're going to set a list of minimal requirements for the ethical conduct of cluster randomized trials. And yes, we're going to take into account the constraints raised by feasibility because of large cluster sizes and the types of interventions involved. But what I don't think we're going to be doing is giving people a free pass just because things are difficult. So I hope you won't be too disappointed with the final product.
Okay, thank you very much indeed. First of all, I would just like you to thank Andrew and Kathleen for what I think has been a really, really interesting session.